You know, we often think of biological sex as a pretty simple switch, right? Male or female. But what happens when the biological blueprint isn't quite so straightforward? Today, we're going to dive into the fascinating science behind what are known as disorders of sex development, or DSDs. And we're going to do it by looking at the real clinical questions that doctors face. So, let's jump in.
Here's our game plan. First, we'll get a really clear handle on what DSDs actually are. Then, we're going to rewind all the way to the beginning and look at the genetic blueprint. From there, we'll see how hormones translate that genetic code into physical development. And finally, we'll wrap up with a modern patient-first approach to diagnosis and care.
So first up, what are DSDs? Now, instead of just throwing a textbook definition at you, let's start with a real-world scenario, something that medical teams actually encounter. I think this gets us right to the heart of the matter.
Okay, so imagine this. A baby is born, and the external anatomy isn't clearly male-typical or female-typical. Now, obviously, this can be a really stressful and confusing moment for everyone involved. So for the medical team, what is the single most critical, immediate first step? What do you do?
Well, the answer might actually surprise you. The #1 priority is not surgery. It's a careful, comprehensive medical evaluation. This right here immediately pushes back on a really common assumption and shows us that the goal is to understand first, not to intervene right away. And that leads us to the clinical definition. DSDs are congenital conditions, which just means they're present from birth, where the development of someone's chromosomes, their gonads, or their anatomy is atypical. And here's the really crucial part, the big shift in modern medicine. These are seen as natural variations in human development, not just as diseases that need to be fixed.
All right, so to really understand these variations, we have to go back to the very beginning. We've got to look at the genetic blueprint itself. Let's dig into how those initial instructions for sex development actually get written.
So for most people, the story starts with chromosomes, right? Either 46XX or 46XY. But honestly, that's just the first page of a very complex instruction manual. The real action happens with specific genes on those chromosomes, and even on other ones, that act like these powerful master switches, flipping developmental pathways on or off.
And here we have two of the most important switches. On one side, you've got the SRY gene. You can think of it as the on switch for developing testes. When it's there, it usually kicks off the male typical pathway. But on the other side, you've got the WNT4 gene, which is absolutely crucial for ovarian development. It not only guides the female typical pathway, but it also actively suppresses the male one. It's this amazing biological push and pull, and any little change in that delicate balance can lead to a totally different outcome.
Okay, so we've got the genetic code, but how does that code actually get translated into physical development? I mean, how do we get from genes to a person? Well, that's where hormones come in. They're like the chemical messengers that take the instructions from the genes and tell the body what to build.
Now, when these hormonal signals get mixed or rerouted, it can lead to different outcomes. And it turns out that the single most common cause of DSDs in individuals with a 46XX karyotype is a condition called congenital adrenal hyperplasia, or CAH for short.
So what is CAH? Basically, it's a group of genetic disorders that mess with the adrenal glands. You know, those little glands that sit right on top of your kidneys. And the main issue is a big imbalance in how the body produces some really crucial steroid hormones.
This slide shows the chain reaction perfectly. Think of hormone production like a factory assembly line. Well, in the most common type of CAH, a key worker on that assembly line, a specific enzyme, is missing. This creates a roadblock. The factory can't make an essential hormone like cortisol. So what happens? All the raw materials on the conveyor belt get diverted down a different path, which leads to an overproduction of androgens, which are male-typical hormones.
Okay, now let's flip the script for a second. Let's look at another scenario. What if the genetic blueprint is 46XY? The testes develop just fine, and the body is pumping out plenty of testosterone. But what if the cells of the body are completely deaf to that message? What happens then? This table lays out exactly what happens in a condition called complete androgen insensitivity syndrome, or AIS. Check it out. The genetics, 46XY, and the gonads, testes, are the same in both columns. But look at the hormones. In AIS, the body makes lots of testosterone, but it's like it's shouting into the void. The cells can't hear it because the receptors are inactive. And the result? Female typical external anatomy. It's just a stunning example showing that it's not just about what hormones you have, but whether your body can actually use them. And all of this brings us to our final section,
how the medical field actually approaches diagnosis, and, most importantly, patient care today. It has really moved away from a purely surgical model to a modern, multidisciplinary one that's way more holistic.
So when a DSD is suspected, the evaluation is incredibly thorough and systematic. It involves looking at the chromosomes with karyotyping, measuring all the hormone levels with assays, and using non-invasive tools like a pelvic ultrasound to literally see the internal structures. It's all about getting a complete picture to work from.
And this brings us right back to that first question we asked about the newborn. The crucial principle, the guiding light in modern DSD care, is this. The consensus is clear. Any surgery that isn't medically necessary should be delayed until the individual is old enough to provide their own informed consent. The patient's voice, their autonomy, is absolutely paramount.
So after looking at the genetics, the hormones, and the principles of patient care, we're left with a much bigger question, aren't we? When we learn about these intricate, varied, and totally natural biological pathways of sex development, it makes you stop and think, how does this science challenge or expand our understanding of sex beyond a simple, rigid binary? It's a question that really shows just how much this amazing biology has to teach us.